Great. Good morning, everyone, or maybe good afternoon, wherever you might be. My name is Joan Batorf, and we are calling in from UBC Okanagan today. And before we begin this session, I do want to acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. And I'd like to acknowledge that wherever you might be joining us today, whether it's near or far, I'd like to acknowledge the traditional owners and caretakers of those lands as well. And it's a beautiful sunny day here in the Okanagan, and so we're especially appreciative of the opportunity to live, work, and play here. So before we begin, just a few housekeeping things. You'll notice there might be a closed captioning box that can be moved on your screen, or if you want to turn it off, you can do that at the bottom of your screen. And we encourage people to type in your questions and comments at any time during the presentation, and we will share them with our presenter following the presentation. So there will be time for questions and comments, so encourage you to jot things down. So today's event is a webinar that we co-host here at the Institute for Healthy Living and Chronic Disease Prevention here at UBC Okanagan with the North Okanagan Hospice Society. And we've been doing these webinars for a number of years and delighted to have this partnership with the North Okanagan Hospice Society. So I am going to now turn it over to Clara Dick, who is the Education and Resource Leader with the Society, who's going to introduce our speaker. Clara.
Thanks, Joan. As you say, we also are so appreciative of our ongoing partnership with UBC Okanagan Institute for Healthy Living and Chronic Disease Prevention. It's our pleasure to introduce Robyn Thomas. She's a Master's of Arts student, Community Engagement, Social Change, Equity Theme, Interdisciplinary Graduate Studies at UBC Okanagan. Robyn will be presenting Developing the Role of the Volunteer to Support Caregivers of Children with Medical Complexity, a Delphi study. Robyn, I'm going to turn it over to you.
Great, thank you so much, Clara. And I'll just share my screen here. One moment. Okay. Everyone can see. Let's see. Practiced earlier, but that's when you start to wonder if it doesn't work. Maybe.
Yes, we can see everything. It looks fine.
Oh, great. Thank you so much. Okay, so here we go. Okay, sorry, I wanted to make sure it worked before I jump right in, but hello, yes, my name is Robyn. I'm so honored to be here this morning to talk about what I think is just such an important field of work. I'm calling from the Stolo and Coast Salish territory, actually, of Harrison Hot Springs. I'm currently visiting my family here. I'm really happy to be able to connect with you all from here. And yeah, so the title of my presentation is Developing the Role of the Volunteer to Support Caregivers of Children with Medical Complexity. And I was, this wouldn't be possible without the incredible supervision of Dr. Barb Pessett, my research supervisor, and my committee as well, Dr. Hal Seiden and Dr. Michael Treshow. And of course, funding from the principal chair in palliative and end-of-life care, Barb, as well. And so we'll just jump right in. So I just wanted to provide a brief overview of what I hope to go through today, including a bit of background information on my thesis and sort of setting the scene of the work we did. And this work was broken down pretty much into two phases. So phase 1 and phase 2. And so we'll go into those sequentially. There we go. And then we'll jump into conclusions and should have time for questions at the end. So we'll begin this background discussion with really the root of this study, which is children with medical complexity. And there is a growing population of children in Canada born with complex care needs. And that's mostly due to advancements in medicine and technology. And so the definition that you see on your screen by DeWan and Cohen is that this is a group of children with really high family identified needs, complex chronic disease necessitating specialized care, functional disability, or high healthcare utilization. And so the families in our study really had children with a range of medical conditions. Most were multi-system organ disease, which are often very rare genetic or congenital conditions. So you see heart defects, neurological conditions, cerebral palsy. But there was really 3 core similarities between the families in our study. And that was a really high need for caregiving, for one thing. And also that many of these children face a lot of uncertainty into their survival into adulthood and will really need palliative care. So in turn, we can really think about that many of the children in our study were at different stages in their medical trajectory. So just in our focus group, for instance, we had 2 participants who had children who were in really early stages of their illness trajectory. They had just gone through that diagnosis phase. But then we also had participants who were reflecting on their child who was now an adult. And we also had participants whose children were nearing the end of life period. And so while the term children with medical complexity, it may be a bit of a mouthful, but it was very intentionally used rather than children in palliative care, because there are many overlaps between children with palliative needs and those with complex care needs. So children who require palliative care may often have medically complex conditions. But we wanted to use that term because it really umbrellas, a range in the field, and we wanted to make sure that we weren't excluding certain groups of children who would otherwise likely have a palliative designation. And that's really based on that journey into palliative care being very different for children versus adults. We'll talk about that in a bit more detail. And so while children were the root, parents were really the focus of the study. Oh, sorry. And so these parents often, the parents who often have children with medical complexity will fulfill the role of family caregiver. And that's a really complex and overwhelming role that I'm going to try to get into a bit here. So being a family caregiver requires significant personal, financial, and physical commitments and expertise on the behalf of the caregiver. It's a very intersectional role as well. So it involves being a mom or dad, a partner, a nurse, a care aide, a teacher, a doctor, a pharmacist, a patient advocate, a researcher. And so through balancing these many roles, family caregivers really become the expert provider to their child. And so their role can include instrumental caregiving, personal caregiving, informational, emotional, medical caregiving. So that could be from personal care for your child, eating and dressing. And then we can look into managing care information, advocating for their child at school or in the hospital, or managing complex care at home like trachectomies or dialysis machines. And then we have emotional support as well. So you're supporting your child through grief, through fear, while also feeling those emotions yourself. These multiple demands really create an immense caregiving burden for parents to balance. And it's honestly hard for me to stress the experiences that these parents go through and just the stories that I have witnessed in this thesis on a day-to-day basis. And that's really why I included that image on the slide of, you got one person, but perhaps there are multiple faucets that they have to tap into to be able to be that family caregiver role. And so I wanted to include this care map from Adams et al. From the literature that really kind of displays that there are so many dynamics that parents have to balance. And this is interesting because it's actually only focused on the child, and it's jumping into the services and the care that child will need. But then we also think about the fact that if we put the parent at the center of this, we would also have their employment perhaps, or their personal relationships, or their other children as well. And so the growing number of families of children with medical complexity in Canada really necessitates a system that is prepared to provide comprehensive and high quality holistic care for this group of children and their families. And so the system is often under the term pediatric palliative care. So this definition by Spicer tells us that pediatric palliative care is supposed to be an active and total approach to care provided to children with life-threatening conditions and their families, from the time of recognition of diagnosis or of disease throughout the illness to the time of death and beyond. But I really wanted to talk about framing pediatric palliative care and thinking about the social factors and contexts that really impact pediatric palliative care. And so one aspect of that is uncertain trajectories. So some children may be in palliative care for a very long period of time or for the entirety of their life, depending on the severity of their condition, the time of diagnosis. And many children will also have concurrent medical treatments and palliative care at the same time. And so an early approach we know is really necessary, but that doesn't always happen. And that's really rooted in the progressive nature of many of the conditions that children with medical complexity have, which makes it quite difficult to predict prognosis or to really assess how those lifelong complications and risks a child may face, how they might play out. So there often is a lack of consensus regarding best action in the care of a child with medical complexity. There's an interesting study that tells us that parents are more likely to believe in the likelihood of a cure for their child's illness than their care providers, although there is no difference in likelihood of survival. So when we look at that parental denial and that perhaps lack of certainty in prognosis and diagnosis even, we can see that there might be a lack of advanced care planning. So there might be more aggressive treatments at end of life. And then we also have that aspect of, in a bit of a philosophical perspective, that dying children are not philosophically accepted in our society. This was expressed in literature quite extensively. And also in our study, caregivers talked about feeling that outsiders look in on their family and their life, and they can't really handle it. They have to almost turn away from it because it's such a difficult reality to actually understand. And so it becomes a very isolating experience for caregivers and their family. And then in Canada, we also have huge accessibility issues. So there are 13 programs across Canada that provide pediatric palliative care, but they're all in major urban centers. So there's really a huge gap in care for families that are outside of these regions. And I believe only one participant in our study actually had told us that they lived in a rural area, but we had 25% say that they must drive multiple hours for their child's care. And that can often be because there's also not a lot of specialists in pediatric palliative care. In 2015, there were only 51 physicians in Canada who specialize in PPC, but if I didn't mention before, there's 97,000 children who have complex care needs in Canada. That was as of 2016, so that number has also grown. And so whether or not they live in certain major city centers, they may still need to travel to get to that specialist care. And what happens then is that we might have to separate families. So we have siblings and parents that are separated, and that can create a huge pressure on caregivers as well. So when we consider the landscape of pediatric palliative care, it becomes clear that many of the needs of family caregivers can actually go largely unmet. And so one aspect of that is a lack of appropriate childcare or respite services. And that really has to do with the challenge of finding someone who could appropriately provide care for their child. Outside of a hospice like Canuck Place does provide respite services, but outside of that, it can be very difficult for families to actually get a break. And there's also that challenge with finding information, and that really translates into a decision-making burden as well. I remember one mom describing to me that she felt like she existed in valleys between great mountains of specialties, trying to learn everything, trying to carry them up on those mountain tops, but there's no bridge. There's no bridge between them. There's also challenges with emotional support. And that was huge in this thesis that we'll get into, but that's not just during the child's trajectory, but also into bereavement. And caregivers can really struggle with reconciling their identity as both a caregiver and as a parent. There's this very interesting kind of field about the good parent phenomenon, because you find that many caregivers will describe that they just want to be a good parent to their child. And each parent may hold a very deeply personal and internal good parent definition, which can be affected by how their child's care plays out. And into bereavement, caregivers discuss experiencing a real sense of abandonment from the health system after their child dies. Well, while that's happening, parents are facing deep grief, emptiness, emotional survival. These are all terms that have been used. extreme fatigue. And we read that 18 years after the loss of a child, bereaved caregivers may still face high rates of depression, decreased well-being, and an increased risk of health problems, organ issues, and natural deaths as well are much higher. And then finally, there's this concept of a fragile home life, which really is rooted in the family dynamics that are perhaps beyond that care map. But when we think about how that can impact, how care can impact a sibling or another parent or extended family, and it can make a very unpredictable and really just fragile experience in the home. So in consideration of the unique needs that caregivers face, we conducted a rapid review of the literature in the fall of 2020, where we explored different interventions that exist for supporting caregivers. And so an avenue of support that was promising was volunteerism, and specifically volunteer navigation in pediatric palliative care. So what is volunteer navigation? Volunteer navigation, well, navigation, let's start there, is a family and person-centered health model designed to help patients and families maneuver complex and burdensome health conditions. So navigation is defined by Delphi 2018 as working in collaboration with patients, families, and communities to negotiate the best fit for the needs of persons, their families, communities, and resources. So you're improving access to services and resources, you're promoting community connections, and it's really under that umbrella of a culturally safe and palliative approach to care and compassionate care as well. And navigation can be volunteer-based. That's where we get that volunteer navigation term, which is focused a bit less on perhaps systems and system navigation and more on quality of life. So NavCare is an established program across Canada that is a volunteer-led navigation-based intervention for supporting older adults with advanced chronic illness and their families living at home. And NavCare follows that compassionate community approach to care and that palliative approach to care. And so the goal of NavCare, as written on, I stole this slide from my team, so I can't take credit for this beautiful picture, but it's to provide specially trained, mentored, and experienced volunteers to work with persons and their families living with declining health to improve their quality of life. So we can ask that question, what do NavCare volunteers really do? And what they do is they really aim to improve quality of life by providing early support, building social connections, building volunteer capacity, optimizing resources, developing relationships, assisting with tasks, listening to people when they're going through difficult times or difficult decision making. And so multiple recent studies across 8 diverse sites where NavCare has been successfully implemented really tell us that NavCare is feasible, acceptable, and a satisfying intervention, not only for participants and their families, but for volunteers and coordinators as well. So at older adults cite benefits to their holistic well-being. Volunteers talk about developing meaningful relationships. And so what we really think about from considering NavCare and through that rapid review was that it's possible that an adaptation of NavCare for a family caregiver population in pediatric palliative care could be successful. So there's a limited but emerging body of evidence that a model like NavCare could really be acceptable and feasible. And so we have really established volunteer programs, children's hospices, like Rogers House or Canuck Place, that have shown tremendous success with volunteer orientation, training, feedback, and performance. But outside of the hospice setting, we also see success in telehealth programs or in-home programs as well. People come in and try to support families with their needs. And so it may be beneficial to really draw on available evidence here to perhaps see how we could establish a volunteer navigator role. And so that's sort of the background information that I wanted to get into. And now we'll talk a bit about our approach in this study. So that above discussion really informed our approach. So this was a mixed method study using a modified Delphi and focus group method over 2 phases. And we'll get into what that all means as well. And this approach was really meant to be community-based in the sense that we wanted to have a dialogue with caregivers, and we wanted to ensure that any steps from this thesis would really be embedded in their voices and their lived experiences. and to be ultimately very relevant to what they need. And so we'll talk a bit more about the Delphi method, but just to briefly say that focus groups are a way of collecting qualitative data, which involves engaging a small number of people in an informal group discussion focused around a particular set of topics or issues. And so we'll jump into what a Delphi method is as well. But the two research questions that really guided the two phases that will come are: what are the unmet needs of family caregivers of children with medically complex conditions, and how may a volunteer support and address these? Let's talk a bit about what the Delphi method is. The Delphi method is a qualitative research approach used to gain consensus on an issue. It involves an iterative multi-round survey, which is presented to a group of experts in a field of question. And so for the purpose of this thesis, experts are a group of people with various types of expertise. So we didn't define expertise in this thesis as a hierarchy of professional achievement or academic achievement, but through recognizing that different pathways, such as lived experience, can foster expertise in a field of knowledge. So to provide an example of how the Delphi method works, let's say there's a series of priorities that may be given to a group of experts in the field. They will each separately rank or rate these items on a scale of, let's say, importance. Then this data is going to come back to the research team, who conduct an objective and impartial summary, so that only the items that are above a certain consensus level or rating are going to be sent back to the next round, back to the participants for another round of ratings. And that goes kind of on and on until you reach a desired consensus level. But above all, it is confidential. And it is meant to be anonymized as well. And so today, the Delphi method has been applied in many social and economic topics. It is extensively used in medical and nursing research. And it's really based on two assumptions. One, that group consensus is more valuable than individual opinion. And then secondly, that anonymity can eliminate subject bias. So we're removing factors like groupthink or other social influences that could impact the decision-making process. Now that we have that bit of a backdrop on our methods, we'll jump into phase one. And so again, the focus of phase one was, what are the unmet needs of family caregivers to be potentially met by a volunteer? And that was done through one Delphi survey with family caregivers, and also a focus group interview, also with family caregivers. And the outcome of this was a list of volunteer roles. So to provide a bit more detail on what really went down, it began with the rapid review, which really gave us that background of what perhaps these roles could be, which helped us to prepare the initial list of items. And then we had some really successful recruitment with a family research liaison at Okanagan Place, which was mostly online through bulletins and email. And then I had a phone call with participants to sort of develop rapport and confirm their eligibility to the study as well. Eligibility was really just based on having a child with complex needs based on that definition that we discussed earlier. And so in round one, caregivers were given a list of roles. And they were asked to rate them on the scale of importance. So 1 being not at all important and 5 being extremely important. After that, the data was brought back to us where we summarized it. We removed any roles that had a mode of less than 3. That was the consensus level that we agreed on. We anonymized that data. But then we were really lucky with timing because the focus group interview occurred around the time where we hadn't begun round 2 yet. So we were able to take some of that data as well and summarize it into potential roles and bring that into round 2, which was really great because it still went through that process of group consensus making. And it really gave us that opportunity to sort of vet out those extra roles from the focus group. And then they had their final ratings again on that scale of importance. And then, yeah, at the end, we had that final list of volunteer roles that came out of that. Now we'll get into some of the findings of phase one. So we ended up having 20 participants take part in the first round and 18 completed the second round. Half of participants were the sole provider of care, and most of them had more than one child. I think most had 2 children. pretty homogenous in terms of gender and ethnicity. We had mostly Caucasian moms. But it was really exciting. We only actually had anticipated about 16 people, but we had a lot more interest in that, which was really great. And again, had a range of conditions and experiences from these caregivers. So for the focus group, we basically just recruited from caregivers who had already conducted round 1 of the survey. And so the only criteria was really to have completed that. And it was really exciting because we got participants from Edmonton, Toronto, Victoria, Vancouver. So we got a really geographically diverse range of participants, which I think really helped us to inform the rest of our study here. So I'll jump into the findings from phase 1. And essentially from, again, combining that data from the Delphi and the focus group, we ended up with 8 domains of needs that could be met by a volunteer role. And so I think what we'll do is go through each of these in a bit more detail and talk about, what that really meant for caregivers and what were some of the highlights in our data. So the first domain was communication. And the findings here really aligned with previous literature that caregivers can face a lot of challenges in communicating their family's needs with others. And so we do have that represented there with communicating with the school and perhaps healthcare providers. But a piece that really came out that was very interesting was centered around communicating my child's lived experience to health providers. And so that mostly came actually from written responses, and it was rated as extremely important in the second round. And so caregivers talked about wanting to feel safe to talk to their care providers without shame or stigma, but also wanting their providers to understand the holistic dynamics that can impact their child's life and care. And then another interesting facet that came out of this was communicating my child's health with my other children. So in the interview, caregivers discussed feeling unsure about how to best communicate with their healthy children, especially during times of distress when their sibling, the sick child's health was deteriorating. And there's a lot of literature surrounding how caregivers attempt to protect their healthy children from difficult details about the sibling's illness. And then in turn, these healthy siblings feel like their parents have enough to worry about. They don't really want to really further burden their parent. So there's this reciprocal silence that really happens between parents and their healthy children. And this can be very destructive to an open and healthy relationship. And that was very, very prevalent in our findings. Notably, though, there is research with community-based hospice palliative care volunteers that tell us that volunteers can act as a mediator for channeling information between patients and other family members, including children. Something I really wanted to do in this presentation was include some of the more poignant lines that were expressed by caregivers in this study for each domain. And so this one on our left tells us how family caregivers felt like they were quite isolated from perhaps those who didn't really understand what was happening. It was too much for them. They just couldn't handle what was happening to us. And then on the right here, we talk about, we had a lot of caregivers talk about having to consistently reiterate their child's medical condition in so many settings, not just at the hospital, but in the school or in hospice settings, or just with family members. And it could become quite overwhelming for them when they had to consistently reiterate their child's condition. And then sometimes that was met with perhaps a bit of feeling as though they weren't the expert in their child's care. So while they had all that knowledge, that wasn't always acknowledged by healthcare providers. So the second domain that came out of our data was surrounding daily life and chores. And this is a really interesting and really robust category here that really tells us that caregivers balance a very complicated home life, and it can be difficult to perform and complete household tasks. So caregivers express to us how some tasks that might seem relatively simple to outsiders can cause considerable stress and pressure for them. And it really ranged, as you can see on this list here, but it had a lot to do with really balancing that life in terms of the house, but also their other children, extracurriculars. Transport was quite huge as well. But we had a really interesting bimodal distribution from here, someone to help complete paperwork and applications for support services. And so with that item, it was rated as both 2, which I think was slightly important, and 5, which was extremely important. And so there's a big difference there. And so as a study team, we had to take that data and really think about how socioeconomic factors or other social influences could be impacting why some caregivers answered 5 and some answered just 2. And that's why we ended up keeping certain bimodal distributions that had such a vast difference. And you'll notice here that we did separate daily life mentors into someone to help with X and someone to help with finding me support with it. And that was really thinking about a volunteer capacity, and also the idea that there could be more established systems or organizations that could address things like home adaptation or grocery shopping or meals. And so we've got some more quotes here, which this one on the left makes me, it reminds me of what we mentioned about, sometimes things that might seem very simple really aren't, like just making breakfast. And then this part on the right really, really highlighted, I think, a huge message that came through in our data, that it's hard sometimes for caregivers to imagine someone actually helping them with the care of their child with medical complexity, but that doesn't mean that there is no room for support or help. If they can get help with other things around the house or the other things that are a burden on them, that can really help them to take a bit of that pressure off and to get a bit of a break in that way. So the third domain was emotional support. So again, it was very clear that there's a huge emotional role of caregiving, and that's obviously well documented and occurred in the study as well. The one that I wanted to point out was help us make a roadmap to manage all of our needs. That came out from written responses as well. And it really highlighted the need for more family-centered approaches to care coordination for a child with medical complexity. So merging a family's household and caregiving tasks with a child's medical needs as well. And like that map that I showed earlier, most literature places focus on the child's health-related needs, such as their school and extracurriculars and hospital appointments. But a lot of caregivers talked about how it's hard to compartmentalize all those aspects of their experiences to just one child. And so if they could have some sort of a map that would help them think through, okay, what is the next week or next month going to look like for each of us, that could be quite helpful. I thought this was such a beautiful quote from one parent, that they would want someone to come in the home and be a caring presence to help them process out loud the emotions and experiences of going through various health crises and pains and losses, pulling together and feeling supported and held as they transit this time together. And that was really clear in the literature in the study, that caregivers can feel quite isolated and alone in their care, and sometimes just having someone else to talk to can actually make a huge difference. The fourth domain was information and knowledge. And this was actually the most highly rated category in our data, which was quite interesting. The caregivers really mentioned how difficult it can be to find information about pain, sleep, nutrition, and also the overwhelming nature of information online as well. And they often talked about having to figure everything out themselves, or really just feeling like they had to go through word of mouth or hope that they can, finally reach the right person that can tell them about what they need. Mental health came out a lot too, about needing more resources and information about how to support their children and their family throughout the illness trajectory. And yeah, this was an interesting story as well, that caregivers can feel like there's no one telling them where the resources are. They had to call 100 people. Maybe someone would refer you there, and then you would find that person and find little nuggets along the way. And it's interesting because another study that was done on the Navigator in New Brunswick for telehealth, that was the #1 request that they got on their phone service. It was people looking for information related to caring for their child. Respite was the fifth domain. And we know how important respite is from the literature, but it's typically talked about in a really traditional model of support for the child with medical complexity themselves. But what kind of came out in this thesis was needing to almost expand that definition into more indirect or alternative ways of helping caregivers get a break. And so that can include such a range of things that we really just wanted to simply put in there, help me get respite so I can get a break, that last role here. because it really sort of envelopes that idea that it might not necessarily look like one thing all the time, but really just caregivers need someone who's willing to be flexible and adapt to what getting a break can look like for them and their family. This quote also was very powerful that came out. Just, caregivers talked about wanting to have fun as well. They want a volunteer who would get everyone together, go for a movie, eat popcorn, flexible, likes to have fun, and recognize the importance of fun as part of their family's life, and really including the whole family in that as well. It was interesting to hear from some caregivers who had had experiences with programs in their towns, where people had gone together and supported their family to go apple picking, and then they had support for their siblings, and they had food available, and they helped with the transport. And the mom that told us about this really shared how it doesn't always have to be about the care or those more serious aspects of that journey, but sometimes it's just about helping everyone have fun. The part with decision making came out as well as domain number 6. And yeah, we talked about decisions about treatments and care, taking notes, but discussing what is reasonable for my child as they grow and want to do more things, that came out from parents from the written responses and from the focus group. And that was interesting because it really highlights how difficult transitionary periods can be. And caregivers talk about that in many ways, as well as, the financial deficit that can happen when their child turns 18, or wondering what's going to happen with grants and support services. But it was also just, there's so much fear surrounding their child's health. And so it can be quite a difficult time as their child does grow and trying to sort of understand what could be within a reasonable scope of their child's capacity. And they talked about wanting someone to talk about their concerns, but not to always necessarily provide advice, but really to just be someone who can actively listen in a safe space. They're not going to feel judged, but they're also not going to have to, hear someone else's opinion on what they want to do all the time. I thought this was really powerful as well, that a lot of the advice that caregivers remember being given would have worked well if their child was an only child and if they had infinite time. But we had 2 other kids and jobs and lives and things. It was like reading a romance novel and you realize your life isn't quite like that romance novel. Domain number 7 was sharing the caregiving experience. And this domain was really, really interesting as well, because there is that aspect that is connecting caregivers with the community and with other, peers that maybe have gone through a similar thing. But there was also an aspect that was sharing the caregiving experience with the family and with the volunteer. And so that's what those second two role items really are: supporting other children to be involved in that experience, and also having someone who can help spend one-on-one time with their child. But an interesting thought kind of came out of our data as well, that there's an issue that can arise in the sense of emotional boundaries. And so caregivers talked about, they found that they'd get calls at midnight with someone flipping out because their child had gone into the hospital with various infections, and how difficult that can be. And so that was a really interesting piece that really influenced our competency development in thinking about how we can have caregivers engage with peers with lived experience, but we also have to think about the importance of emotional boundaries and ensuring that that's not going to deplete caregivers, and making sure that there are those spaces. And then again, having other children feel more included in their care and not being excluded from such a significant part of family life. So domain 8 is qualities of help. And it was really interesting because this was one that wasn't at all involved in the original list of roles that was presented. And it really has to do with what is help going to look like, who are these volunteers supposed to be, and what training would they need, and what would those interactions look like. And so we'll start with just experience and training. So caregivers talked about not really caring too much about gender or age, but they really, really stressed an importance for a preference for a volunteer who does have lived experience And that didn't just come out in this category, it really came out in every single domain. That caregivers would feel a lot more comforted with someone who already understands what it's like to be in their shoes, and someone who is familiar with the system, who can provide advice, as it says in that quote, someone that can say, yes, I heard that comment too, and I understand your point of view. And yeah, as well on the right here, caregiving experience is needed, that lived experience is needed 100%, nothing else can really replace that. And that just came out across the board. And we also had personal traits. And so we talked about compassion, emotional intelligence, recognizing the importance of family centeredness in the care, and being a volunteer. And so I remember one caregiver talked about having, either you're comfortable in the presence of that person or not. And all that really matters is that you have someone who wants to be there, connects with your family. And they talked about having a bit of a trust issue sometimes because they have so many traumas caused by a system that's designed to serve them. And they often can have that rotating sphere of people coming in and out of their care that can be quite difficult on their children. So sometimes caregivers almost wanted to protect their child from any further influences that could come in, like a volunteer. But if they're not going to be there for a long time, it wouldn't really feel necessary, which really takes us into interactions with volunteers. Caregivers really wanted someone who was frequently going to come by to their home. It had to be in home as well, and over a long period of time. But they needed someone who'd be flexible too and recognize that their house is often, going through different things in each day. So sometimes they might want help with the house being clean. Sometimes they might want help with a sibling. And I think that really comes down to quality of life priorities and developing a relationship with a volunteer who's able to be quite responsive and receptive to the needs of families and their children. So that was a lot of phase one. That was a lot of info, but I'll briefly get into phase two. So the question of phase two was, what competencies does a volunteer need to meet the roles established in phase one? So this involved just one Delphi survey with experts in pediatrics, palliative care, and volunteer navigation. And what came out of that was a list of volunteer competencies. So to again provide a bit more detail on how this played out, we took that final list of volunteer roles as well as some quotes, and we presented them to professionals in the field in round one. And they were asked in an open format, what knowledge, skills, or abilities, so essentially competencies, would a volunteer need to be able to meet that role? We took them back, we anonymized them, we created them, we developed them into a competency list, and then they were sent back again to to professionals who again rated it on that scale of importance from 1 to 5. And at the end of the day, we got that final list of volunteer competencies. So what was really interesting was we ended up having 8 participants who came from different fields. So we had professionals with backgrounds in volunteer navigation, but we also had community members in pediatric palliative care and participants who had experience as volunteer coordinators at a pediatric hospice. The competencies matched up exactly to the domains. So we had 20 sub-competencies and 60 learning objectives that accompanied them, spanning over those 8 domains that were established in phase one. And what was really interesting was that we pulled out of phase two is that we did a comparison of the evidence-based NAV care competencies and those that were established in this thesis, and they were very closely aligned. And so that comparison really demonstrates the potential for adapting NAV care curriculum to address creating a volunteer training curriculum and program for family caregivers of children with medical competencies. NAVCare did have a virtual volunteering aspect, which obviously didn't match up to this as we didn't really explore that, but that obviously would be a really interesting aspect to explore as well in the future. And so I'm not going to go through all of the 60 competencies for each domain, but I wanted to provide an example of what they looked like. So we had sub-competencies on the left, understanding how to effectively communicate, supporting caregivers with communicating, and communicating as a health advocate were the 3 for this domain. But then we broke those down into a bit more specific details about what the learning objectives would be. And it was the learning objectives that professionals were rating, because we wanted to really ensure that they were going to get into that detailed discussion about what this could really look like. We talked a bit about developing skills of active listening, nonverbal communication skills, being able to recognize the multidisciplinary teams involved in a child's care. And really a lot of this has to do with really getting to know a family and being able to identify what's important for others to know about their child and what's important to keep track of to support that caregiver. And so what was really interesting as well, as I mentioned before, was how this mapped onto the NAVCare curriculum. So for example, advocating on behalf of caregivers to other servers or health providers matched really well with the NAVCare curriculum of advocating to overcome barriers for resources, or advising families on negotiating for resources. It was really interesting because in NAVCare, we have facilitating discussions about future planning. And so that kind of popped up in our data as well. And so to summarize, what I've kind of gone through quickly here is the groundwork was really established on the unmet needs and what a potential volunteer role could look like for caregivers of children with medical complexity and their families. It needs to be individualized. It needs to meet the specific needs of each unique family. It needs to be in the home, and it really needs to be something that is family-centered. And then we also developed the groundwork on volunteer training curriculum and what that would need to look like based on those competencies. So lived experience is going to be necessary. It's going to have to be a comprehensive training on a range of roles, but it's absolutely likely to be feasible when we look at that comparison to the NAVCare training curriculum. And so I just briefly wanted to mention in the future, it'd be really exciting to take that groundwork and actually develop a training curriculum, perhaps building off of established programs, also looking into what places like Back Place or other hospices have done, and then perhaps taking that and conducting a feasibility and acceptability study. And of course, since this was in the scope of my master's thesis, there wasn't really time to do as many interviews or perhaps iterative rounds of the Delphi survey as I would have loved, but that would be an exciting opportunity to really take that curriculum and explore further opportunities to engage with caregivers and see their thoughts on it and ensure that it is really embedded in their needs. And that is everything for me. So thank you so much for listening along. I know that was a lot of information, so I really appreciate it. And I'd love to take any questions that anyone may have.
Great. Thank you so much, Robyn, for such a brilliant presentation and so clearly presented. Mm-hmm. Well done. We do have some questions and comments already. And we have people in our audience who have had some personal lived experience as well. And so I just want to recognize that they have shared some of their experiences in the chat as well. And so we're delighted to have you with us today. We have a question from Lisa about about who the participants were in round 1 and 2 of the Delphi, and were they the same people or different people? And I was also wondering how many were caregivers themselves and whether they were mothers or fathers.
Yeah, absolutely. So in the first phase, we had all caregivers. They all had extensive experiences in caregiving for their child, often more than 10 years. And that was really established during the phone call that I had with participants. So we kind of had a conversation where I got a sense of what they might have been through and what their child's care was. They were all mothers in the study. And I think that might have been the 2 points there. There was 20 participants total, and I think 18 completed both rounds. And then in the focus group, it was the same. We delved into the same group. So after they finished that first round, we just asked, would you be interested in participating in a focus group conversation about this a bit more? And then out of that, we ended up having 5 participants who were available, and then 4 actually were there. And so that was the first phase. In the second phase, it was pretty much convenient sampling with professionals in the field of volunteer navigation. But I was really lucky to connect with the volunteer coordinators at Connect Place as well, who really provided that important insight into more of that pediatric palliative care perspective, as well as people who had experience, had gone through the process themselves. And so there was really that interesting wisdom and expertise that came from from the diverse knowledge of palliative care and also voluntary navigation in the second round. Hopefully that answers the question.
Yes, I think it does. Yeah, very much so. I guess and Clara, you might have a question you want or a comment you want to make before I take over here. Why don't I leave it to you?
Oh, sure. Robyn, I'm curious about this. Your participants really identified that they wanted to volunteer with lived experience. Was that lived experience specific to having a medically complex child, or was it a lived experience as a caregiver for somebody of any age who had a palliative diagnosis?
That is such a great question, Clara. And it really was the former. It was wanting someone who had experience caring for a child with medical complexity. Yeah. And I actually felt like it was quite highlighted that caregivers, because they often feel so misunderstood, that they really wanted someone who actually had perhaps walked that journey themselves. And so, yeah, that was really strongly said, that it needs to be that sort of experience. Yeah.
Yeah. I have one more question, Joan. I'll just
go ahead,
if you don't mind. I love how you shared that the NavCare training current curriculum kind of overlapped a little bit with what you identified. Was there any additional specific training you identified right off the bat?
Yeah, that's such a great question. You know, I'd want to go into it to answer that a bit more, but I think like one of the things would probably be being able to connect with the child themselves and being able to connect with the family as a whole. I think that might be one aspect that really came out. And I'm trying to think, I remember there was another aspect, I think it had to do with information and knowledge that I felt expanded a bit further, where it really had to do with wanting someone who could specifically understand the dynamics of hospices and children's hospices and that kind of aspect. So it was almost like the NavCare curriculum provided a really good starting point or almost an umbrella, but there are some specifics within each category that are more specific to having a child with medical.
Great. So I'm curious if you were thinking, you know, just basic knowledge of developmental stages of children and that sort of thing. Is that?
You know, maybe that could be something that would be important, but, you know, I'm not sure, because sometimes I feel like it would really depend on the family, because sometimes caregivers talked about wanting someone who could understand the medical condition and understand where their child's at. But then other times they just want someone who would connect with their family and want to be there and connect with their child. So so I'm not sure. I think it could look different for each family.
Right. And that's actually a hallmark of NavCare program, which is focused on quality of life, what's important for that family. Yeah. So that's lovely. Thank you, Robyn. Joan, I'll pass it back to you.
Yes, we have a question from Cody, and she asks, I'm curious how generalizable the idea of lived experience is to care, from palliative care to physio, psychotherapy. And I kind of wondered about that too, in terms of lived experience, given that there are many childhood complex illnesses that are quite different, and their trajectories can be quite different and uncertain. And so I guess I wondered about this lived experience as well, and how broad that could be, because it's going to be really hard to find an exact match.
Yeah.
Right. In terms of.
Yeah, that's such a good point.
Everything. So.
And thank you, Cody, for that question. Yeah, sorry to interrupt, but no, I think that's such a great point, because you're exactly right, Joan. How can you really have someone that's going to be specifically understanding and applicable to a certain family's situation? But when I think about what parents talked about in the context of lived experience, it was often related to not wanting to be judged or wanting to have someone who really understands. They talked about feeling like when they divulge information to a healthcare provider, they feel like it's going to need a call to social services because they're not doing their best. And so sometimes I wonder if it's maybe less about, again, you know, knowing developmental stages and knowing everything about a specific experience, and more about what it can be like to be not understood by many people. And I think maybe that would be the extent of generalizability. But yeah, that's a great point. Thank you for that question.
I have a question, Robyn, about you had 20 participants in the first phase and 18 in the second. Average age of these moms?
Yes, you know what? Let me jump into, I want to make sure I get it right, but I think it was 34 to 45.
Okay.
Let me just check. Yeah, so average age was 45 to 54. Sorry. So,
Okay.
but it did range from 25 to 64 plus, because we did have one mom who was really reflecting. And so,
Okay.
yeah, but the majority of participants were, it was a present experience. It was, currently happening that their child was very sick. Yeah, that was interesting.
Yeah, I'm just interested in this fear of child services. And is that an age thing? Is it a desire to be a good parent, and how that could really influence their experience of caregiving? I see there's a comment here.
Oh, yes, from Lisa Olson. Thanks, Lisa. I'm also curious about the ideas for competency and training. Do families express any ideas around safety concerns? In studies I've been involved in with parents, also referred to needing to be able to trust alternative caregivers in terms of safety around their children. Might this be a component of training?
Yes, absolutely. That did come up. And so there was an aspect of, is that person trained in emergencies? Are they able to address the needs that might happen in an emergency situation? But then there was also an aspect of, am I going to really be ever able to trust that child? And that was an interesting aspect, because we talked about traditional respite roles and having someone who cares for that child, and perhaps alone or whatever the situation may be. But I actually think what came out even more so was not actually really wanting that, but wanting more of perhaps indirect or less traditional roles where we're helping out with the whole family, as simple as, light chores around the house and helping with transport and being there for conversations and doing meaning-making activities. So it was less perhaps going to be in situations where there could be a really dire emergency and the parent wouldn't be present. I feel like that was something that absolutely came up. But it would need to absolutely be a component of training that the volunteers would be able to address, perhaps at some level. And I'm actually not sure in NAVCare what that level is, but I know that I think hospice volunteers do go through their basic first aid and that sort of thing. But it would definitely be something to really look into, because it would just be so important, of course.
Mm-hmm, mm-hmm.
Yeah.
That's great. Well, I have to tell you, there are many comments in the chat about what a wonderful presentation. People really enjoyed this presentation, as did I. And Lisa says, thanks, that's so interesting. And I agree, this is really interesting topic. And I know that there are many families out there hoping that this research ends up actually supporting the development of volunteer navigators specifically for this group of families. So I see we've run out of time, and I know we could continue this conversation longer, but I do want to thank you very much for this presentation today, and hope that you are able to continue this work, perhaps with Barb, and that Barb also carries on this work. It's really an important area. Clara, do you want to have the last word here?
Oh, well, thank you, Joan. Again, Robyn, wonderful work. Thank you for this. Our children are our future here in Canada, so supporting the children and their families will make us strong. And so, yeah, great work, and looking forward to the next iteration.
Yes,
thank you
absolutely.
so much. Thank you.
And thanks everyone for joining us today from wherever you're joining us. And Cody has asked about getting the PowerPoint. We've recorded the session, and so anyone who's registered will receive a link to the recording. So watch for that in your email box. So thank you once again, everyone, for joining us, and hope you're able to join us again in the future. Bye-bye.
Thank you so much.